Good morning, ladies and gentlemen. I am Dr. Hakan Yıldız. I am gastroenterologist. I am work at the Acıbadem Hospital. And my topic today, role of endoscopic ultrasonography in diagnosis of the gastrointestinal diseases. We, we daily practice, we use two devices, radial device and linear device. Radial device is the give the and the VMing of the lesion is the 360 degree and the like the CT and the sagittal is the VMing. Linear device what is the give the VMing of the lesion and the 180 degree, but we take the biopsy from the lesion. You can see needle in the lesion, we take the biopsy easily. So these two devices and or daily practice we use. And the but and the main drawback of the endosonography, if the lesion is far from the lumen, we use the lumen, is the stomach lumen, is the and the esophagus lumen and the duodenum lumen. This is very important. Lesion, if the near this lumen, we can describe and the lesion is the detailly and we take the biopsy. This combination of an endoscope with an ultrasound probe in 1980, endoscopic ultrasound guide final aspiration in early 1990, ultrasound has revolutionized the field of both diagnostic and therapeutic gastroenterology. It has transformed itself from the research tool to tool to utmost clinical importance due to its ability to visualize layer of the gastrointestinal tract and structure and organs which lies in the close proximity to gut valve. And then the sonography, endoscopic ultrasound guide final aspiration has become the preferred method of the sampling in the majority of the pancreas mass, mediastinum, lymphadenopathy, intra and extraintestinal abdominal mass, periintestinal lymphadenopathy. USFNA has been mostly successfully utilized in the pancreatic lesion and peripancreatic lymph node. You can see last 5 to 5 years EUS FNA development, and there are a lot of important development in the EUS, but EUS FNA is very important for us. Is the 1980 attachment of ultrasound probe, the endoscope 1993, development of the new needle. This needle is flexible. We take the biopsy easily. After this time, you can see other site for the needle. Take the biopsy. And the 2011 is the change and the or needle. And the next generation needle. This needle is developed to procure FMB needle, fine needle, biopsy needle, and this needle take the core biopsy, core tissue. So this the change, and the other lesion is the other lesion is the and the lymphadenopathy. This
This video demonstrates the wicking or capillary technique for procuring core tissue at EUS. Once the mass is punctured, the stylet is removed slowly at 10 to 15 centimeter intervals. During this process, the back and forth needle movement of FNA must be continued. A core tissue is then expressed onto the slides as shown in this video. On histopathology, the pancreatic mass was confirmed as adenocarcinoma.
Yes, you can see example from the fine needle aspiration and a very efficient method for the pancreatic lesion.
This video
Diagnostic success. and communication between the endosonographer and the cytopathologist is the key to successful EUS FNA. A cytopathologist service should be involved early in the planning process for establishing an EUS guide tissue acquisition service. Using an algorithmic approach to diagnosing a patient will facilitate the correct diagnosis. Fine needle aspirates or biopsy are used widely for EUS, computer tomography, and other image guide biopsy techniques. Material obtained from a fine needle is generally dispersed as single and small group of cells. The monolayer smear created from a fine needle aspirate is very important to decipher the tail of nucleus and cytoplasma that is superior to many other modalities. Recently, new developments have allowed acquisition of the core biopsy utilizing endoscopic ultrasound guide route. These samples have the advantages of the providing tissue architecture. Endoscopic needles, varying size of the EUS instrument and needles are available on the market. Choice of the needle may also influence histology findings. Needles are changed last decade. Mostly we use 22 gauge or 25 gauge needles are used. And you can see all needles. This first using needles. There is a the hello is here, and we take the fine needle aspiration. But next generation is the fine needle biopsy, and the first generation is you can see is the bevel is here, and this bevel in the tissue and in the lesion, and it cut the lesion. And the second FMB, second generation FMB, this bevel is reverse, and you can see reverse. So you take the biopsy is and the reverse. Is the third generation biopsy and the sharp core and the fork type and the procore forward facing bevel. This third generation is more core tissue, but maybe give the increase the side effect. And the other important issue for us, rapid on-site evaluation, ROS, or immediate histology evaluation. One way to ensure adequate material from an FNA procedure is the use of ROS. Specimen adequacy is more than 90% when a histopathologist is present in the endoscopy suite for the ROS. Most false negative EUS results are caused by inadequate sampling. Is very important. ROS is the increase the diagnosis 10% is very important, but a lot of endoscopy suite we can't see any histopathology or pathology. Rapid on-site evaluation, minimum number of passes is the histopathologist say is I can see the lesion, we stop. Apparate triage of limited specimen, the core tissue is very important. After this the lesion of the describe which modality. And the encourage the communication is very important. And we sometimes taken the biopsy lesion, but lesion is will be is the necrotic. So is the histopathologist say us and there is the necrosis, so we changed our trace. Most effective way to reduce sampling error is ROS. Use fine needle biopsy advantages. The use of EUS guide needle core biopsy has recently demonstrated significant promise in review of the lymphadenopathy as well as from other solid organs. These needles utilize thin bores and have been found to be useful not only to establish the diagnosis of the lymphoma, but also characterize cellular architecture, which is more important in disorders such as follicular central cell lymphomas. Advantage and challenges associated with the EUS FMB procedure. Advantage, no ROS, not necessarily ROS, but disadvantage, inadequate communication. Failure passes advantage, but ATP rates might be increased. Time saving, but lack of the appropriate tissue triage for ancillary testing. And the advantage, EUS-FMB architecture. Disadvantage, cannot determine if tissue from target site is accurate. And the advantage, liver core biopsy, you can take the liver core biopsy, but disadvantage, expensive, smaller, and fragmented cores. Tissue for ancillary studies, advantage, but increased adverse event and tissue injury. And good for stoma, rich tissue, but disadvantage, immediate feedback is lost. But in the good for diagnosis of primary lymphomas is not disadvantage. Not any disadvantage is the very useful for the lymphoma diagnosis. In the EU specimen, EU FNA specimen processing, histology similar, storage liquid material, heme prepared, and cell block histologic section. Use FMB specimen processing, core biopsy solid material, tissue block and the tissue block histology section. Causes of the false negative diagnosis, technical difficulties. Sometimes lesion far from the lumen, so taking the biopsy very tough. Sampling error, and we take the other side. And interpretive errors is the sometimes such as the chronic pancreatitis and the biopsy maybe not give the clear clue. And pancreas cancer. And the EOS is very valuable device for the pancreas cancer diagnosis and staging. Fourth leading cause of the cancer-related death, and the 48,000 deaths per year. 5 years relative survival rate of only 10%. It's a very low 10%. It's trend in 5 years cancer survival, and out of cancer in the survival is the better right now. But you can see is the last this purple line, and the survival not change, and our treatment not efficient right now. So is the why? Because we diagnose is very late, and we should detect early pancreas cancer. Endoscopy is very valuable if they detect the pancreas cancer. Endoscopic ultrasound is the most sensitive imaging modality for the diagnosis of the pancreatic ductal adenocarcinoma, especially lesion less than 2 cm in the size. Use guide fine needle aspiration biopsy is the gold standard for tissue acquisition in pancreatic mass lesion. Diagnostic yield can be optimized by the use of second-generation car biopsy, needles, and sampling lesion adapting the finding maneuver. As you can see is the computer tomography. This is the computer tomography, and the pancreas, there isn't any lesion. In the EOS clearly show us the lesion is this. Is the taken the biopsy is the pancreas adenocarcinoma. And the endoscopy for the subepithelial lesion. And the subepithelial lesion very beneficial because and the indel lumen so is the we clearly described. You can accurately differentiate a moral lesion from eccentric compression against the gut wall. Imaging diagnosis of subepithelial lesion with EOS is based on its layer of the origin and internal echo characteristics. As guide tissue acquisition is useful for pathologic diagnosis of subepithelial lesion. Endoscopic therapeutic method for treatment of subepithelial lesion can be chosen according to information obtained by the EUS. And the subepithelial lesion diagnosis, ultrasonography, computer tomography, and magnetic resonance imaging have been used, but they are not insufficient. Use clearly visualize gut layer. And this I want to show clearly describe all layer. This is the stomach, and you can see 5 layers. This is mucosa, and the muscularis mucosa, and submucosa, muscularis propria, and serosa. All layers will be see clearly, so we can say the diagnosis sometimes is the and the lipoma, leiomyoma, and the subepithelial lesion types is we can describe easily lesion layer. So this is the clue for the diagnosis. But a lot of time we have to take the biopsy. In this layer we can see is the gastrointestinal tumor, fourth layer. This is the out of time is the this place, and the and leiomyoma fourth second, and the lipoma third. We can describe layer we have in the preliminary diagnosis. Subepithelial lesion use FNA FMB lesion and the immunohistochemical examination to achieve definitive diagnosis of the subepithelial lesion. Use FNA performance is not good for the GIST, but use FMB core biopsy and increase the diagnostic performance. Lymph node and the endoscopy, mediastinal and intraabdominal lymphadenopathy is the cost-effective and reliable modality because out of time we take the biopsy by the TrueCut biopsy, but EUS take biopsy is the easily and describe the lymphadenopathy clearly. Prevent unnecessary surgeries because there is any cancer we can describe the metastasis in this place. Use FNA of deep seated and the lymphadenopathy. There are a lot of lymphadenopathy such as granulomas, infection, and lymphoma. And we take the biopsy and we describe the lesion is to give the diagnosis. Non-Hodgkin lymphoma use diagnosis. Early report suggests that the FNA was not always useful to test diagnosis of the malignant non-Hodgkin lymphoma. The accuracy used FNA varies between 50 and 99%. But FNB, final biopsy, take the core biopsy, so give the information and superior to FNA for deep-seated lymphoma. In the nerve area and the endoscopy and the hepatopathology. And endopathology has emerged as new subspecialty in the gastrointestinal endoscopy, used in the diagnosis, prognosis, and treatment of the patient with liver disease. Used at liver biopsy safe, well tolerated, and high quality core. Type of the liver biopsy. There are 3 main biopsy: percutaneous liver biopsy, transvenous liver biopsy, laparoscopic liver biopsy, and we use the percutaneous liver biopsy out of the majority case, but use is very efficient because we can see the lesion, we take clearly and there is any the vessel we describe. This description of the EUS biopsy with linear echo endoscope in the 2007. EUS biopsy can provide comparable or even superior tissue compared to this obtained by the transjugular or percutaneous liver biopsy. EUS FMD liver biopsy, you can see this the liver biopsy is the as in the this first and the picture in the low power magnification, second, third is the and high power magnification, and there are is you can see all and the cell and the portal triad. Thank you for your attention.